I will discuss a very important topic, adult-onset still disease. Adult-onset still disease is a rheumatological condition that is characterized by fever that is intermittent and high-grade, leukocytosis, arthritis, joint inflammation, and also it has leukocytosis, high WBC count, increased serum ferritin, anemia, and salmon colored rash. So this is an overview of adult onset still disease. So it is a condition that is characterized by high spiking quotidian fever. It means it is spiking to more than 39 degrees centigrade once or twice daily, and then between these attacks it becomes normal. So it is intermittent fever. It has dramatic evening spikes with chills and may be with sweating and profound fatigue. There may be flu-like prodrome. Sore throat is frequent and early clue for the diagnosis of adults still disease. Characteristic rash, salmon-colored pink rash, and it is non-pruritic, that is it is not itchy, but it is maculopapular rash and appears mostly when there is spike of fever. So two things, first one is intermittent high grade fever, and next thing is salmon colored pink rash that comes with fever spikes. This rash appears on the chest and back mostly, but also on the proximal limbs, and it may worsen when a person scratches. Also, patient has polyarthritis and arthralgia, but this appears later as compared to the fever. There is symmetric involvement like in rheumatoid arthritis, and it is migratory or persistent. Mostly it involves the wrists. But knees, ankles, and metacarpophalangeal joints may be involved. But mostly it involves the wrists. It can evolve to chronic erosive arthritis if it is left untreated. So there is deformities in the joints. There is also involvement of the lymphoid tissue and organs. There is generalized lymphadenopathy. So generalized lymphadenopathy is also caused by adult onset Still's disease. There may be hepatosplenomegaly and mild hepatitis is also seen. There may be serositis, that is pleural or pericardial effusion can develop with adult onset Still's disease. How will you diagnose it? You will diagnose it clinically and also by using these labs investigations. Serum ferritin is very high, often more than 3000 nanograms per ml, and it is a marker of inflammation here. It has also very high ESR and CRP because these are also high inflammatory markers. There is leukocytosis that is characteristic for adult onset Still's disease, and mostly this is neutrophilia. So there is leukocytosis in adult onset Still's disease, and anemia of chronic disease is also seen. ANA and RF are usually negative, and in this way you can differentiate it from other autoimmune diseases and rheumatoid arthritis. So ANA and RF are usually negative. So the labs you should do are serum ferritin that is raised, very high ESR and CRP, leukocytosis, and CBC shows anemia, and negative ANA and rheumatoid factor. You can use a mnemonic for its symptoms and signs. First one is fever, F, frass, fever, R, rash, A, arthritis, H, hepatosplenomegaly, and S, sore throat. So this is frass, fever, rash, arthritis, hepatosplenomegaly, and sore throat and serositis. So in case of adult onset Still's disease, how will you manage and treat this condition? The patient may have pain and fever. For this you can use paracetamol and other NSAIDs. Systemic corticosteroids are the mainstay of treatment initially in the disease. Prednisone is given as 0.5 to 1 mg per kg per day, and then it is tapered gradually. Mostly rapid response to prednisolone is seen. Sometimes you have to go for IV methylprednisolone pulse in severe cases. It is given as IV 500 mg or 1 gram IV stat IV. Steroid sparing agents can be used when there is long-term control is required. Because steroids have a lot of side effects, you don't want these. Therefore, steroid sparing agents are used. Steroid sparing agents like methotrexate is used mostly. This is a first line demand and it is the best for joints plus steroid sparing. Leflunomide, azathioprine or alternatives can also be used. In case of biologics, we go for either interleukin 6 inhibitors or interleukin 18 inhibitors, but mostly interleukin 6 inhibitors are used and interleukin 1 inhibitors can also be used. Interleukin 1 inhibitors are anakinra and another drug is canakinumab. Canakinumab. Very interesting name. Canakinumab. So interleukin 1 inhibitors and interleukin 6 inhibitors are mostly used. Interleukin 6 inhibitor is tocilizumab. It is good for joint and systemic disease. TNF inhibitors are less effective like infliximab. These are less effective and therefore these are not used. So we use interleukin 6 inhibitors and that is tocilizumab and interleukin 1 inhibitors like anakinra and canakinumab. For life-threatening complication, that is actually macrophage activation syndrome. Macrophage activation syndrome leads to hemophagocytic lymphohistiocytosis in which there is generalized lymphadenopathy, splenomegaly and also pancytopenia and bone marrow failure. So this is a life-threatening complication and for this you have to go for IV pulse steroids. That is you should give methylprednisolone IV 1 gram IV for 3 to 5 days. So IV pulse steroids are required for this macrophage activation syndrome MAS. Furthermore, cyclosporin or anakinra plus minus IVIG and biologic agents can be used. So life-threatening complication that is seen with adult-onset Still diseases, macrophage activation syndrome MAS. So this is all about adult-onset Still disease.